Now, what I'm starting off with is all the research questions that were sent to us over the last few weeks from people that couldn't attend. And then I've been trying to slot in the questions that you've been asking in the chat where they duplicated something. And then there's a few that I've put on at the end that weren't. So bear with me, because there's a hell of a lot of them. And what I would suggest is we'll get through as many as we can during this session. And then any that are left to be answered, we'll be talking to Dave Adlam about how we might do that and get back to you. Okay, so my first question is a research one, and this relates to something said earlier. So can we still return blood sample packs that were provided in early March, or is it too late to utilise this? Dave? Alice, rather. Alice.
As in samples that were taken in early March, or packs that haven't yet been used for blood samples to be taken?
I think somebody received a pack which they didn't send back to you, so they're just asking, can they send it now?
So if the blood sample is recent, yes. If the blood was taken in March, then not.
Just check the expiry date on the pack. That'll be the key thing. But the biobank is open again now. So providing the blood taking pack is in date, that's the key thing, just to check all of the components of it, that it hasn't expired. Then it can be sent back. At the moment we're sort of holding fire a little bit on sending out packs and things, just because of the certain uncertainties and things at the moment. But that's certainly something for potentially again for the future. Okay,
thank you. And Alice, the other question is, do you have enough healthy volunteers now?
So we have quite a few that we're waiting to invite. And obviously with coronavirus and things, it's sometimes difficult to invite people from lockdown areas and things. We may need more, but we have quite a few people on the list at the moment. So I think I'll let you know if we need to recruit some more.
Okay, thank you. So my next question is an exercise one. Many are advised to keep to moderate cardio exercise after SCAD. And so the questions are, is that forever? Is there a safe way to return to a higher level of exercise and exertion when training? And can we do weight training, high intensity types of things? And is swimming safe? So a nice big group of questions there about exercise.
So probably worth going back a step, which is, what is the association between exercise and SCAD? There are probably two associations, one of which is less firmly established than the other. The firmly established one is that there are a very small number of patients for whom SCAD occurs during what's called isometric exercise. And isometric exercise is the stuff that makes you go purple in the face, so lifting weights, essentially, that kind of exercise. There is also a sort of less clear association with higher levels of exercise, sometimes in the run-up to the event, but often it's not so clearly associated with the timing of the event. But it's not, that is less clear, that association. So in terms of exercise after SCAD, generally speaking, the first thing to say, which we've already heard about, is that cardiac rehabilitation has been shown to be very effective in building confidence in a controlled environment in returning to activities, and is something that should be encouraged. That's the first thing to say. In terms of exercise, we know that exercise is good for the heart and good for the head, we say. In general, what we suggest is avoiding the extreme end of exercise. So the first thing we try to avoid is that sort of extreme isometric exercise. And what I say with weights is it's the thing that, it's the sorts of weights that mean that you have to alter your pattern of breathing. So the things that make you go red in the face, you have to hold your breath to lift it up. Those are things which are probably best avoided. Toning exercises, things that you can do whilst breathing normally, are absolutely fine. And, you know, clearly in life, you know, picking up kids, things like that is, you know, stuff that is necessary and obviously absolutely fine to do. In terms of sort of more what we call aerobic exercise, you're sort of running, jogging, all of those kind of things, I'm fairly permissive. I, you know, generally speaking, say to people that, you know, it should be just a little bit off the peaks of exercise that maybe you would consider. You don't want to be, you know, pushing yourself to the edge of what you're capable of and beyond. Those maybe are the areas where the risk increases, but certainly exercising just a little bit within yourself is fine. Sporting activities are fine. You know, we would probably advise against what we call sort of more extreme levels of exercise. So, you know, running up the side of a mountain or, you know, things, again, that are above and beyond what your body would be used to. So in general, I think exercise is a good thing. I think it's really about being sensible and just maybe not going to the extreme end of that.
Okay, thanks, Dave. So another question related to exercise is that many of us wear a device that measures our heart rate. If the question that I've been asked by several people is, if they were to start having another SCAD, would their heart rate change, giving them a warning?
So the first thing to say is I'm not a massive fan of heart rate targets for exercising in post-SCAD patients. I just think it's very difficult. It's very different from individual to individual, and I'm not massively convinced that there's any data that suggests that staying within a particular heart rate target is something that's a lower risk. I think it's more sensible to just to have that kind of common sense limit in your head about just a little bit beyond pushing yourself to the extreme ends. In terms of using a heart rate monitor as a predictor of kind of a recurrence, I don't think that's a great way of doing things, partly because there are lots of other things which can change your heart rate. And I think you'll end up with lots of false positive and false negative sort of hits where you're thinking that things are bad when they actually aren't. In terms of recurrence, my general experience is that, I think there's a few things to say about it. First of all, yes, it does occur. We have to get our heads around that. But it's not, so common in some respects. The latest data suggests somewhere around 1 in 10 patients will have a recurrent event within the first 3 to 5 years after the first event. After that, we don't have a lot of data. The risk probably falls, but maybe not to zero. Flip that number on its head. That means 90% of patients are not having a recurrence in that time frame. We also know from the data from the MRI study that I mentioned earlier that the outcomes in SCAD, the prognosis is very good. The injuries to the heart are very small. And so even if you're unlucky enough to be in that recurrent group, you're still going to do very well. My experience with recurrence is that it's usually unequivocal. We know that there are challenges sometimes in distinguishing recurrence from post-SCAD chest pain syndrome, which again we know is a very, very common and sometimes very difficult to manage problem. But my experience is that most people who have a true recurrence know that this is something that they need to get checked out. And so I don't think you need a heart rate monitor to be able to help you to distinguish. I think if you have a true recurrence, you're going to know there's something that needs to be checked out without having heart rate monitors and things. I think the risk with the heart rate monitor is that you go down a blind alley with something that's turns out not to be important.
Okay, thank you. So referrals next. So Abby and then Dave, how long does it take to get a referral?
Thank you, Karen, and lovely to see you all, including our patients and David and Alice. In terms of referrals at the moment, so different hospitals will have different policies. In general, it's about a couple of weeks, especially for new referrals. I think if somebody has an urgent need to be reviewed, again, we can do it within a week or two as well. What I would say is that a referral from their GP or whoever is the practitioner can be emailed across. We are using this difficult system called ESR, which triages referrals. Sometimes referrals do get lost, but the idea is that we kind of keep the new patients within 3 to 4 weeks to be seen, and kind of if anybody is more urgent, we can add them in and see them much quicker if needed.
Okay, thank you. And Dave at Leicester?
So I think, we would struggle to keep to those timelines, I'm afraid, and it's just the volume of patients that we're looking after these days. Again, we would, we do our best to sort of try to prioritize things, but I think it would be at least 3 to 4 months from a receipt of a referral to a new patient appointment at the moment in Leicester. And, I think it's just one of those capacity challenges that we have. But, we will get there in the end and talk to you about your SCAD and what to do about it when we get there. But that's the reality, I think, at the moment.
Okay, and is there any chance that there will be another cardiologist that gets interested in SCAD or is interested in SCAD currently that might want to start up a SCAD clinic?
So I think that there are some political challenges, and we have talked a little bit about them in the past. So one of the challenges is that at the moment, SCAD is not recognised as a sort of specially commissioned service. So essentially, we run the clinic on slightly on a sort of grace and favour basis in Leicester. That our trust allows us to see lots of patients from out of area, rather than seeing local patients, and that has been a challenge from time to time. I think we'd love to get the service recognised as a specialist commission service, because obviously that gives a small amount of resource and also gets the NHS management off our backs. But that has proved to be challenging, essentially, for largely financial reasons. The barriers seem to be up at the moment for expanding specialist commissioning within the NHS. And we're kind of keeping our eye on that and seeing what options there might be going forward. And I think if that could be achieved, then there certainly are other people, other clinicians in the UK who potentially would be interested in taking, establishing SCAD clinics. I think it would happen, relatively quickly if there was some funding to support it. So it's, that's a tricky thing. It's something we haven't yet managed to kind of get over yet, but hopefully maybe in the future we would be able to achieve that.
Okay, thank you. So now on to a FMD question. Many people get FMD diagnosed after their SCAD. Do you think SCAD is a version of FMD or a completely different condition?
So that's a bit of a billion-dollar question in the SCAD research world at the moment. I think, let me talk a little bit about FMD first of all. What we know about FMD, and I think this is quite important, is that first of all, it's common. It seems to be at least a third of SCAD patients will have FMD somewhere in their arteries. And FMD is essentially a description of what the arteries look like. They look like a string of beads. They have little dilations and narrowings, little dilations and narrowings. However, despite the fact that FMD is relatively common in SCAD patients, it's probably not particularly clinically important. So it doesn't seem to cause problems either. So most people in whom we find FMD, it doesn't seem to be causing a problem at the time. And from what we've seen so far, it doesn't seem to develop into a problem. And so at the moment, if you like, it's almost something that's a marker of patients, of certain patients who have SCAD, rather than is something of particularly clinical importance for the patient themselves. There are other arteriopathies, so abnormalities of the arteries, that we find in some SCAD patients. So these can be little swellings, which we call aneurysms, or sometimes other dissections. So you can sometimes have a dissection in another artery in the body that may not be causing any symptoms at the time that it's identified. And it is for that reason predominantly that we recommend the brain to pelvis imaging in patients, in order to be able to find those things, because those are things that we may want to follow up. We may want to do sort of serial scans to make sure that they don't cause any issues. And occasionally it may alter our medical strategy. So, you know, sometimes if we were to find a dissection elsewhere, we might be a little more inclined, for example, to continue with aspirin in somebody who's not required to take it for other reasons, if you see what I mean. But there are good reasons to look for these things. But these things are not so common. And I think it's important to say that, again, if we look at the SCAD registry and the follow-up of the SCAD registry, we do not see events or problems arising from FMD or indeed these other arterial problems that arise. So that's not to say there are never any problems related to the other arteries, but it is to say that they are certainly very uncommon. So is SCAD and FMD the same thing? There are some people who think that that is true. Some recent data from the genetic studies that have been talked about already in SCAD, and comparing the findings of those genetic studies with FMD, suggests that there is definitely some overlap with some of the common variants. The first common variant that we described also occurs in FMD, interestingly, also occurs in migraines and in carotid and vertebrobasilar dissections. So it's a common variant that marks out a number of conditions that have some overlap. However, they do not seem to have the same genetic signature. So they are more likely, in my view at the moment, to be related and somewhat overlapping conditions rather than the same thing. And I think that probably also reflects a bit what we see in FMD patients. So patients with primary FMD, whose starting presentation is with FMD-related problems, actually SCAD is very, very rare in, or it seems to be very rare in that group. So overlap in my view, but not the same, although the jury is definitely still out and there's still work to be done here.
Okay, thank you. So going on to sort of other medical things. So I'm going to ask Abby and then Alice now about hormones. Hormones seem to play a big part in SCAD, anecdotally. So for women who've had a SCAD in their 30s, 40s, and are now approaching menopause, is there any evidence that there's a risk of a further SCAD during that time when all the hormones go haywire again?
Thank you, Karen. It's an incredibly important question, and actually it would be good to, I don't know where the data is in terms of the research outputs from David Adlam and Alice with regards to it. Certainly when we started off the research, we saw some patterns that perimenopausal women were, at that point, that we were seeing an increased influx of women at certain age groups, suggesting that the hormonal changes could be a predisposing factor or an associated factor with it. I'm unable to comment to say, you know, does that increase the risk at that point in particular? Because I don't have any data to hand to say that, you know, kind of perimenopausal hormonal changes will increase your risk from being, you know, from having SCAD at a young age to further having SCAD 20 years later on down the line. I don't think we've done follow-ups for that long to be able to kind of comment on that data, certainly, but these were patterns that I have certainly seen, and I continue to see, that women do present at different age groups, and there seems to be some hormonal link associated with it. But I will pass that question down to Dave and Alice if they have any data to share, but I haven't seen enough follow-up to say if you're young and you have SCAD, what happens when you're kind of around 50, and does that increase your recurrence? I don't think I could say that I've seen a definitive something that suggests that at the moment.
Okay. Alice or Dave?
So I don't think we haven't done a detailed statistical analysis of this, but sort of echoing what Abby said, I don't think we've particularly seen a signal that people who have SCAD at a young age are more likely to have recurrence. I'm looking out for people with recurrence. I haven't finished the study as yet, but I'm not finding that the recurrence patients I see are particularly people who had it when they were younger and then have it at the menopause. So if we haven't specifically spotted an association at that point, I don't think.
Okay, thank you. Well, that's reassuring for people, I think. So on to a medical question now about, and this is something that comes up quite a lot in our Facebook group. Quite a lot of people get told that their SCAD is not a heart attack. Is this ever correct? Who would like to answer that?
Barely, I think, is the answer to that. So it depends, of course, on definitions to some extent. The overwhelming majority of SCAD patients will present with an acute event, so a sudden onset event. Sometimes there can be a little prodrome of a few days or few weeks where there's some symptoms before, you know, the moment when somebody will go to hospital. But usually when they arrive in hospital, we will find typically the rise in cardiac enzymes, which is used as the definition for a heart attack, if you like. So there's usually some evidence of heart injury as a result of the dissection event. There are a few descriptions of patients who present with, you know, with SCAD who don't seem to have a rise in cardiac enzymes, but in many cases, those are patients whose presentation is a little bit more staggered. And it may be that there was a rise in cardiac enzymes, it was a few days back or a week or so back, and then patient has come into hospital, maybe for for some sort of more, if you like, a later thing which has triggered admission, and that's the reason why. But those are very, very rare cases. However, in terms, I've already mentioned, of the cardiac MRI study, there were 40% of patients who had SCAD for whom on cardiac MRI there was no demonstrable long-term injury in terms of a scar on the heart. So 4 out of 10 patients were in that grouping. So the answer is yes. Technically, I think the overwhelming majority of patients do present with a heart attack according to sort of current definitions, if you like, of what a heart attack is. However, many of those patients who have, if you like, the smaller end of the heart attack spectrum, which is quite common in SCAD, will not have a persisting heart injury of any size of it that's going to be important going forward in terms of the heart's function. So hopefully that answers the question.
Okay, thank you. And that leads on to the second question, which a lot of people ask as well, is that insurance forms can be confusing. Do we as SCADs have to say yes to the question, do you have heart disease or cardiovascular disease?
So you do, yes. And the reason for that is because, as you know and you've heard described already, SCAD does have this association with recurrent events. It's not a high risk, as I've outlined to you earlier, but it's there. And obviously the purpose of insurance is to make sure you've got something in place if you have a problem. And so if you tick the box and say, no, you don't have a problem, then the risk is that your insurer won't cover you if you do develop a problem. So in my view, yes, you do need to say that you've had a heart attack. You do need to say that you've got cardiovascular disease. But there are now insurers increasingly, and again, Beat SCAD have some experience of this amongst yourselves, and also there's a page of insurers listed on the British Heart Foundation website which can be useful. But there are a growing number of insurers who recognise SCAD specifically as a different, if you like, cause of heart attacks and take that into consideration. So often you may find that if you go onto the sort of online insurer where you're sort of going click, 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 as soon as you click the heart disease box, it will chuck you out at the end and say, no, we won't insure you. Whereas if you maybe go for one of the insurers on the British Heart Foundation website, or take advice from Beat SCAD about insurers that people have used that understand SCAD situations better, you may find it's going to cost a little bit more. That's the nature of things, but at least that you will certainly be able to get insurance.
Okay, thank you. So the next question, I'm going to ask Alice first and then Abby. Many people believe their SCAD was caused by stress. Is there any proven link between stress and SCAD? Has there been any specific research done on this particular aspect of SCAD?
So that's definitely something we see reported. By no means all cases, and we see a lot of people who've had a lot of stressful life events that didn't correlate with their SCAD. But we certainly do see people who report having had a bereavement or a loss of a job or sudden, usually negative, not always, life events. So it does seem to be an association that we want to look into. And that's something I'm currently studying. So we don't have data from it because we've still got all our data blinded. But I am looking at whether people with a history of SCAD respond differently to stress, either in terms of simply becoming more stressed with the same event, or whether their blood flow to the heart is different with stress. So that is a question that we're looking to get more of an understanding to.
Thank you. Abby, do you have anything to add to that?
I echo what Alice says. So it is a common feature that we see in people who present with SCAD, that something has happened around the time or leading up to their SCAD episode. Again, there is not been, it's very difficult to measure that because it's a retrospective event. So looking at people's stress scores, they will always associate an illness with a stressful event. So there is an element of association. And I'm glad that Alice will go ahead and look at how people respond to various stresses. Different people will have different reactions to stresses and their stress levels. I guess from a hemodynamic point of view, a stressful event will cause a high blood pressure. It could cause other parameters to change, and that clearly could have an impact on all the arteries of the body as well. And that could be one thing that can be looked at. I think there was recently a paper that did look at, it was an American paper that did look at measuring stress in women who've had SCAD, and they did report the predisposition that overall women who've had SCAD are more predisposed to stress, to kind of reporting more stressful events, and they measured some scores, and those scores were higher. But again, this is very much retrospective data, so it's very difficult to evaluate exactly what that means. But I think as a contributor, it's difficult to comment at the moment, but I'm glad more research will go into it. No one really needs stress in their life, if I could say that.
Well, that's very true. And what I would like to add at this point is that, if you remember, Abby, back in 2016, we actually had a section on our conference which was about the association of the psychological impact of SCAD on people. And Dr. Colette Sohn, who is one of our SCADs, has just been doing some work to update the literature review, which we will be sharing with everybody soon. And yes, you're right, there is an American paper, fairly recent, but still a bit thin on the ground. And I think that's something we'd all like to see a lot more research going on in. So thank you. Okay, many SCAD patients have ongoing chest pain. So we had lots of questions here about this, which is talking about, why are they getting this chest pain post-SCAD? What can they do to improve that situation? What a lot of people found that they got the chest pain at certain times of the month, or when they were emotionally upset or stressed, the link. And again, some questions about, is there any research going on specifically about chest pain post-SCAD?
So I can start here. So post-SCAD chest pain syndrome, I'll just get rid of that, is essentially very common. It's almost but not quite universal that patients after SCAD do experience some symptoms. We call it post-SCAD chest pain syndrome, but in fact the symptoms can be quite varied from patient to patient. The symptoms you've already described. Sometimes they can be premenstrual in women of childbearing age. Sometimes they can be provoked by stresses, they are often, but not always, different in character to the symptoms which happened at the time of the actual SCAD event. It is a very challenging problem. What we have learnt largely from seeing lots of people is a few things. First of all, post-SCAD chest pain syndrome in most patients seems to improve over time. It can take a while. So we usually say to people that, you know, it's usually faded into the background in most patients around the 18-month to 2-year mark after the index event. But even then, there are some patients who may have a purple patch, have a, you know, some sort of emotional event or something which triggers a few days of chest pain. So it can even happen after that in some people. But for most people, it has faded into the background over that time scale. We've also found that the response to medications is rather variable. There are certainly some patients who do respond to medications. Patients who have predominantly premenstrual symptoms can sometimes respond to hormonal treatments, such as progesterone-based contraceptives, Mirena or something like that, that's going to even out the menstrual cycle. That can be successful in those patients. And sometimes we try different anti-anginal treatments on a sort of trial and error basis. Try it for a bit, see if it helps. If it helps, great, carry on. But equally, what we try to avoid in post-SCAD chest pain syndrome is this sort of incremental medication strategy where you start on one anti-anginal, it doesn't really work, so you add another one, and you add another one, and you add another one, and you end up in a situation where you're getting as many symptoms from all of the different medications that you are on as you are from your sort of post-SCAD chest pain syndrome. So I think it is fair to say that this is a difficult problem, but in most patients, it is one that does improve over time. We've also found that many patients develop their own strategies. And I'm a big believer that the solutions to things, particularly difficult things like this, are not always medical. We can try the medical ones, but it was also well worth trying other strategies. The aim ultimately is to try and improve symptoms and improve tolerance of symptoms. And, you know, I have some things in my armory to try from a tablet perspective, but many patients, I think, will say that they've tried, you know, different things. One patient might go for a stroll in the cool air, one might have a rest, a cup of cold milk, or, you know, all sorts of different things that patients will come up with. And those approaches are just as valid in my view. So it's a very common problem. Why? The why question, we don't really know, is the bottom line here. We, you know, we have a number of sort of theories. One is that there's a persistent sort of tendency to sort of a sort of spasm of the arteries. I'm not sure about that, but maybe that's a contribution sometimes. The other thing is that we know just from an anatomy that the little nerves that run in the heart, which are the autonomic nerves, actually run along the side of vessels, along the side of coronary arteries, and it may be that these get disrupted by the dissection. And we know that anything which damages nerves takes a long time to heal, which fits with the longer time scale. So I think with post-SCAD chest pain syndrome, I think we have to manage it in any way we can, knowing that it's going to take some time for things to settle, but that they will, in the overwhelming majority of patients, settle over time. And I guess, you know, I often say to people, look, if you broke your leg at the time that you had your SCAD event, would you expect it to be completely pain-free now? Probably not. You know, these things do take a long time to heal, and sometimes when it's inside, we don't give ourselves, if you like, the same credit as we would if we kind of got our leg in plaster. That actually the healing process can take a bit longer than we'd like. We'd all like to bounce back straight away and go back to things, and sometimes, you know, the body will just, let us know that there was a problem there and it's healing up, but we have to give it some time.
Okay, thank you. Abby, did you want to add anything to that?
I concur with Dave. I think it's a very complex condition. We see it very commonly again. I agree that there is an armory of treatments, from kind of the hormonal stuff with the Mirena coil, if it's around the time of the period, to see if that helps, to anti-anginal medications. I think the only thing to add to that is that I do see that some patients do have worsening chest pain, and if that is the case, I think these patients do need to come back and have some sort of further investigations, just to make sure that there is nothing else that has been occurring or has been missed. There is a few patients where we've seen extensions of dissections, and these are the patients that come back with worsening chest pain. But the ones that the pain gradually gets better, or is not as bad as the first initial pain, I think these are the reassuring cases that we could try to treat. And yes, I agree, everybody finds a treatment eventually that works for them, hopefully.
Okay, thank you. Now, I'm very aware that we're running a bit behind time now, and I've still got loads and loads of questions. So I'm going to just ask a couple more and then bring it to a halt. And what we will do is get those questions to all three of you, and we'll arrange a way of getting those answers back to the people that have asked the questions, if that's okay with you. So another question about medication, and that's about aspirin. So a lot of people have said they understand if you've had a stent, then you stay with aspirin, but they're concerned about the long-term use of aspirin and are asking if there is any alternative.
So the first thing to say, as you've alluded to, is that there are specific scenarios where aspirin is definitely necessary. So the patients who have stents may be one, patients who have bypass grafts perhaps, and also there may be some patients who have either remote arteriopathies. We've mentioned the asymptomatic dissections and things. Sometimes it's a good idea. There's a lot of FMD in the neck vessels. I'm often a little bit more inclined to continue with aspirin, because there's a bit of data from the FMD community to suggest that might be a good idea. And patients who have a bigger scar on the heart, where there's an area of the heart that's really not moving very much, again, maybe those are patients where we might consider keeping going with the aspirin. The actual data outside that context, so if you like, people with conservatively managed SCAD who don't have another reason to be taking aspirin, at the moment there's very little. There's a single Canadian observational study which showed no benefit and no harm of aspirin, so hanging in the balance. But these are not clinical trials. These are observations in patients where you don't really know why one group's taking aspirin and one group's not taking aspirin, and is it a fair comparison? So this is one of those areas where, I hope in the coming years, and it will take time to do this, we would be able to actually answer the question properly with a clinical trial. So there are, potentially reasons in both directions that you can make an argument, and I think the answer is that we don't know. We tend at the moment to be quite conservative, if you like, in terms of saying that unless there's a reason to take aspirin, we don't recommend its continuation. So we'll stop aspirin at the moment. And I suppose that's because I don't feel inclined towards continuing a treatment when I don't have evidence to continue it, rather than the other way around so I'd sort of rather err on the side of less medications than more, unless there is a good reason. But this is an area where, if you like, this is opinion. This is my view on what is the right thing to do. And it's based on experience and my thinking, having spent a lot of time in SCAD and looking after SCAD patients, but it's not based on solid data. And of course, what we're all about in research is trying to get that solid data so that we can actually answer this question with genuine knowledge rather than our own sort of hunch.
Okay, thank you. But is there an alternative to aspirin that would do the same job?
So there are a number of drugs that do a similar thing. Aspirin tends to be favoured as the, as the sort of number one choice. There is a drug called clopidogrel, which does a very similar task, but it is usually used in patients who are intolerant of aspirin for some reason. So, for example, aspirin can sometimes cause a lot of indigestion-related problems. So clopidogrel is sometimes used in patients as an alternative if they're not tolerating aspirin and they have a reason to be taking a drug like that.
Okay, thank you. So I'll come to my last question, and it's another one that is asked by quite a lot of people, and that's for patients are discharged from their care of a cardiologist in varying times from a couple of months to a year, and there's quite a lot of concern about what happens over the years in terms of their care. I think that they feel not that much confidence with their GP, in terms of most GPs have no idea what SCAD is and therefore wouldn't really know what to say to anybody. So it feels like a bit of a waste of time talking to them about it. And so just wanted to know about, for instance, the management of medication long term, and people being a bit concerned that they're lost in the system and don't really know where they should be turning for support should they need it.
So it's a tricky balance is the answer. So if you like, you're looking at on screen now at the sort of sum total of the UK SCAD clinical resource, and you can see that it is not large in terms of sort of specialty or super specialized knowledge. And we also have to sort of balance things a little bit in terms of the fact that if I follow everybody up, I pretty much quickly end up not being able to see anybody new. And, we've already talked a little bit earlier on in answer to a question about clinic weights and things like that. So it's a tricky balance. What we try to do in the SCAD Clinic, and I'm sure Dr. Al-Hussaini will be in the same position, is we try to get patients to a point of stability before we discharge them. And in some patients that have relatively uncomplicated SCAD, maybe no big problems with post-SCAD chest pain syndrome, it's simply a question of getting the clinical imaging done, which we need to make the final decision about the long-term medication strategy, give advice on the long-term medication strategy, and then look to discharge from further regular follow-up. Now, clearly, there is a huge spectrum of people within that, and at the other extreme, you may have patients who've got more extreme or more severe injuries to the heart, or patients who are having bigger problems with post-SCAD chest pain syndrome, and so on. And so there's quite a lot of variation. And also, we never mind it if patients want to come back and be referred again and just review things a few years down the track, or if something changes. We've talked a little bit about pregnancy, for example, or planning pregnancy and thinking about things like that. Sometimes we will get patients who will come back because they need to have an operation or they need to have something else done, and they just want to think it through in terms of, how does the SCAD impact on those things. So re-referral is fine, but I think we also have to accept that with a limited resource, we do have to rely a bit on our local cardiology colleagues and primary care colleagues to, if you like, sort of, carry the baton forward once we get to that point where we feel this is the medical strategy that we would recommend going into the long term.
Okay, thank you. So I think we need to bring the Q&A to a stop here. Now, I'm aware that there are still quite a few questions that have been asked in the chat. So I will be compiling those and getting to you at another time, Dave, Abby and Alice, and we can perhaps come up with some sort of summary to answer those questions and get them back to the people setting them.